Great. So let's get started. You know, the goal of the first few sessions with me in July and August is to try to provide some foundation for pharmacotherapy. And we've had some conversations about the anti-inflammatory drugs and the adjuvant analgesics. And we've also talked about the opioids to some extent, focusing mostly on risk strategies. I want to today run through the foundation for optimizing the pharmacological outcomes of opioid drugs, specifically the analgesic outcomes and a favorable side effect profile. So I'm going to talk about strategies to select, appropriately dose, and manage the side effects during opioid therapy. So everybody should be very familiar with the WHO guidelines for cancer pain, which suggested that patients with moderate pain or greater that's chronic should be considered for opioids. I only wanted to put this up here in order to contextualize it. It is appropriate to promote opioids as first-line drug for moderate to severe chronic pain in some settings, but it's very important to remember, and I said this I think at least in 2 other sessions, that the analgesic ladder was developed for patients who had active cancer, and it was really developed as an educational and advocacy tool in order to try to promote opioid therapy in the developing world. It became extremely powerful as a communication device because it was heavily promoted by the WHO in the latter part of the 80s, 90s, and 2000s, and is still being used today as a tool to try to convince the governments in many developing countries to make opioids more available to patients with advanced illness. It's a broad framework for thinking about opioid therapy in palliative care when palliative care is focused on patients with active illness. Otherwise, it's not a guideline. Not only is it not a guideline in terms of how one thinks about opioids for chronic non-cancer pain, so-called chronic non-cancer pain, or patients who are survivors of cancer, or patients who have a serious illness very early in the course. It's not a guideline to think about the mainstay approach of opioids. But there's also clarity now that what's recommended in the analgesic ladder approach has evolved a lot in the past 25 years. I spoke to you before about how NSAIDs were considered by the expert panel that put this together as being appropriate uniformly for all types of pain. In fact, there were publications saying a major error made by physicians is not carrying through NSAID therapy as patients progress from mild to severe pain. Well, now we know that NSAIDs can be very dangerous drugs that have an adverse effect profile that clearly contraindicates them in some patients. So NSAIDs are not uniformly appropriate for all patients with chronic pain. You need a risk-benefit analysis every time you treat a patient in order to decide whether or not a patient should get an NSAID. And it's clear that step 2 opioids are getting more controversial. There's no reason that every patient needs to be started on step 2 opioids. And in fact, the difference between step 2 and step 3 is not based on pharmacological principles, right? A step 2 opioid is codeine. A step 2 opioid is oxycodone mixed with acetaminophen, and yet oxycodone is also a step 3 opioid. So it's clear that the distinction between step 2 and step 3 reflected only a practice approach. And having spoken to some of the people on the expert panel, it was really based on what was available around the world and not based on pharmacology. So you don't need a step 2. And it's clear that specific drugs are not chosen because of any pharmacological rationale. The expert panel that put this together said aspirin, codeine, and morphine should be the first-line drugs, and you will still read, and I read even last week in a chapter going into a book on respiratory disease, somebody writing that morphine is the gold standard for the treatment of chronic pain in patients with medical illness. I don't know what that means. Why would it be a gold standard? There's no pharmacological foundation to that, right? And finally, interventional approaches have emerged a lot in the past 25 years. When the expert panel came together, they couldn't recommend an interventional approach for sub-Saharan Africa and parts of Asia where there were no physicians who could do interventional strategies, right? So all of this means that the analgesic ladder approach is mostly an educational tool. You can use it to try to talk to colleagues and patients and families about how opioids are the mainstay, the first-line approach for patients with active serious illness, if they have moderate to severe chronic pain, but don't think that the guidelines should tell you what you should do. Okay, so let's jump ahead and talk about what are the actual principles of opioid pharmacotherapy. And most everything that I'm telling you here is based on no evidence. So since we're in 2011 and we all firmly believe in the importance of evidence-based medicine, my first disclosure is to tell you that I have no evidence for anything I'm going to say. My second disclosure is to tell you that you can absolutely take it to the bank. So this is the nature of pain management and palliative care, right? There's very little evidence for what we do, and yet we all have to practice and create, in fact, systems for best practice to support best practice. So we're really reliant on observational data and expert testimony. So my testimony is expert, and I know the observational data, so that's what I'm going to share with you. So the first issue is what do you choose for a patient who is opioid naive or has minimal prior opioid exposure? In the developed world, there's a tendency to choose a combination product containing hydrocodone, oxycodone, or codeine. In this country, the most widely prescribed drug in the entire country is what? No. Vicodin or its generic analogs, right? Hydrocodone acetaminophen is the most widely prescribed drug in America. So that's what we like to do in America. We like to take patients who are opioid naive and have moderate to severe pain, and we like to give them hydrocodone and acetaminophen. You, of course, have the option to choose a single entity, short-acting pure mu agonist, like morphine or oxycodone, and you have the choice to use a mixed mechanism drug, which is quite popular in primary care, particularly tramadol. And the mixed mechanism drugs, as you probably know, are about, well, at least tramadol is about 40% opioidergic, 40% of its mechanism relates to binding to the mu receptor, and about 60% of its mechanism is monoaminergic due to reuptake blockade of serotonin, norepinephrine, and dopamine. Tapentadol is the new one called Nucynta. It's a mixed mechanism drug. There's no clear rationale for using these drugs. There's some early data suggesting that tapentadol may be less constipating. In the randomized controlled pivotal trials, it looked less constipating than oxycodone. And these drugs are, the tramadol is not a controlled drug in the sense that it's not scheduled. Tapentadol is a Schedule II, even though and it's so interesting because the difference between tramadol and tapentadol is the era, not the pharmacology. It represents a change in society, not a change in pharmacology. That's why tapentadol is scheduled and the other drug is not. So the bottom line is that you have all of these options in these patients, and you also, of course, have the option of choosing a long-acting drug right from the start. The important point, which I hope you remember from a prior discussion that we had, is that no one should ever, no clinician should ever fall into long-term opioid therapy. The decision to give a patient an opioid with the intention to continue it indefinitely is a clinical decision that has potentially very significant consequences. So you should never start Vicodin or Percocet and just continue it week after week, month after month, and then not ever take a step back and ask yourself, have we started long-term opioid therapy here? Now, the converse of that is sometimes the patient will come to you and you know right off the bat that you're going to be doing long-term opioid therapy. So, for example, you have a patient who presents with hormone refractory prostate cancer. That patient might live now 2 years or longer, and so, but that patient is very likely to have pain chronically. Day one, you might start that patient on a pure mu agonist, either a single entity short-acting drug for titration or a single entity long-acting drug, because you're making that commitment right from day one. It's going to be chronic opioid therapy. In contrast to that, somebody comes to you with chronic low back pain. They're in severe pain. They're anxious to go back to work. You do a comprehensive assessment. You say, I'm going to give you a short-acting opioid. Try to get you back to work, try to help you in physical therapy. Let's see where you end up. A month into that therapy, it'd be valuable to sit down with the patient and say, are we making a commitment to long-term opioid therapy or are we not? If we're going to make a commitment to long-term opioid therapy, I need to talk to you about risk and benefit. I need to talk to you about adherence. We need to decide what drug. We need to decide how to dose you and treat your side effects. So the bottom line is short-term therapy for acute or subacute pain or chronic pain that you want to experiment with for a while, or longer-term therapy are two separate things. They require two separate assessments and decision-making and documentation in the medical record. And when you do decide on long-term opioid therapy, the patient typically is at that point opioid exposed, often because you yourself have given the patient a short-acting drug, or the patient comes to you from a primary care provider having been given a short-acting drug. That patient is opioid tolerant, and then the drug selection typically takes this form: a pure mu agonist, a long-acting drug preferred, and a short-acting drug being considered for breakthrough pain. By the way, this is, again, based on the total lack of evidence. You may decide in your practice that a mixed mechanism drug like once-a-day tramadol, or soon we'll have twice-a-day tapentadol, you want to use for chronic pain. You don't want to use a pure mu agonist. We have the new long-acting once-a-week buprenorphine patch just came on the market. We're still trying to figure out how to position that. They've had it in Europe for a long time at a much higher dose. We have the low-dose patch here. And in 2 years, this slide may be different. And I might say, for patients who have only had a combination product, no more than 8 doses a day, strongly consider a trial of the buprenorphine patch because X, Y, or Z. So we have all these things on the market in the United States. You need to get familiar with a range of them so that you can do decision-making based on an assessment of the patient, not based on any comparative effectiveness studies yet. But this is the typical approach, and if you guys just got familiar with 3 or 4 of the long-acting formulations, you would do fine. Of course, if you got familiar with all of these formulations, you'd be able to give this talk to a group of trainees in the future. So in this country, we're very fortunate, extremely fortunate. We had a group of policy people and advocates from Eastern Europe visit us here about a month ago, brought here by the Open Society Institute for just a session to talk about the difference between the U.S. and places like Estonia and Tajikistan and that sort of thing. There are now still countries where it's impossible to get an opioid for chronic opioid therapy unless, for example, you're willing to write a prescription every 3 days. Right, in 2011, this still exists. So think about if you have a patient with HIV and pain, or you have a patient with cancer and pain, and you live in Mongolia or Tajikistan or Pakistan. It's not a pretty sight. But in this country, we're very, very fortunate. We have all of these pure mu agonists and buprenorphine. Buprenorphine, remember, is a mu agonist, but it's not a morphine-type pure mu agonist. It's a partial agonist. Pharmacologically, there's some evidence in animal models that all of the pure mu agonists are partial agonists when you get to a high enough dose. In other words, there's a plateauing of efficacy that's not determined by lethality. But in the human model, all of the pure mu agonists, like morphine, typically act like pure agonists in the sense that you keep dosing. As you increase the dose, you keep increasing effect until side effects supervene and you can't increase the dose anymore. In contrast to that, buprenorphine is a partial agonist, and drugs that are not listed here, like butorphanol, which is Stadol, and nalbuphine, which is Nubane, and desicine, which is Dalgan, these are mixed agonist-antagonists. The mixed agonist-antagonists are agonists at a non-mu receptor, like the kappa receptor, and antagonists at the mu receptor. The partial mu agonist, buprenorphine, is a partial mu agonist, and it also has some kappa agonism. It doesn't, in terms of effects, the mixed agonist-antagonists like Stadol and the partial agonists like buprenorphine both have a ceiling effect to analgesia and a ceiling effect to respiratory depression. That's why in this hospital, we created guidelines for patients with obstructive sleep apnea undergoing ambulatory surgery that they be treated with butorphanol, because we had a near-miss disaster, and got together an RCA committee that developed a QI-based policy in order to have patients at risk for apnea to be given a partial agonist, be given a mixed agonist-antagonist opioid rather than a pure mu agonist, out of concern that they would go home and have respiratory depression. Anyway, these are all the options in the United States. I don't have stock in any of these companies, except possibly through a mutual fund. But so I don't really care what you choose. And frankly, I think this year is a great year to experiment and try all of them. You know, I tell patients it's trial and error. We jointly flip a coin. I say, do you feel like a twice-a-day drug or a once-a-day drug? You feel like a patch today? Whatever the patient says, we make a guess. Okay, so which drug is best? We don't know. The variation is large. The selection is by trial and error. Sometimes favorable prior experience is helpful. Often it's not. Favorable or unfavorable prior experience in the acute pain setting doesn't predict what happens with chronic pain. Obviously, right? I mean, you guys who have experience in the PAC, you know how people look when you bolus them with fentanyl or you bolus them with morphine. It doesn't look the same way as when you give them a short-acting oral drug at a lower dose and titrate slowly. It's a totally different model, right? There may be cost and formulary issues that are profound in this country. There's some evidence from observational studies and non-randomized comparative studies that the patches, specifically the fentanyl patch, is less constipating. I just, again, read in this chapter going into this respiratory textbook that constipation is an indication for the patch, way overstating what we know, right? So it's not true that transdermal fentanyl is less constipating based on evidence. But there are observational data to suggest that it may well be. So it's reasonable to try if patients have intrinsic bowel disease or severe constipation. And then if patients have a history of drug abuse, there's a tendency in this country to think about drugs that either, I don't have this here, but either have less street value or are the drugs used in addiction medicine to treat craving. Again, this is not with a lot of evidence, but this is what we do. So if someone has a history of opioid abuse and you say, let me give you OxyContin with Dilaudid for breakthrough pain, you may just be putting so much temptation in front of that patient. It's really partly your doing. On the other hand, if you say, let me give you buprenorphine or let me give you methadone, there may be less temptation. Transdermal fentanyl is less abused than any of the oral drugs. No one knows why. I in fact, was very, very frightened when the transdermal fentanyl system was changed from a reservoir patch to a matrix patch. I don't know if you guys were in practice when that happened, but when Duragesic came out 15, 16 years ago, it came out as a reservoir patch, which basically means there was a semi-permeable membrane with a plastic cover, and within that plastic cover, that pouch, there was a high concentration of fentanyl. The 100 mic an hour patch had 10 milligrams of fentanyl in it, right? So when the FDA approved that, we were all concerned that people would cut the patch and chew the inside and drop dead like flies. That didn't happen. And why it didn't happen, nobody knows. It's a big mystery. But then the matrix patches came out. And the matrix patches, as you know, there are many different kinds of them, have the drug impregnated into the adhesive layer that sticks on the skin. So the thing about the matrix patches is that you can cut the patches or pop holes in the patches and thereby adjust the dose. So then I got very concerned and expressed this in some meetings with the drug companies that patients who are addicted and are smart and don't want to die by chewing a 100 mic patch, reservoir patch, they would just get a hole punch and punch out the holes and sell the holes like LSD used to be sold on little on little paper things? Brooke is saying she remembers. I'm sorry, this is on YouTube. Best not have your mother watch it. Anyway, but it hasn't happened. It hasn't happened. So if you have any patients who are out of control fentanyl addicts, and they're saying, you know, what am I going to do? It's so hard to get injectable. You can, never mind.
Portenoy, just a quick question before you get off that last one. It's also from a non-physician. You were talking about temptation. Did you mean the temptation to sell, or is there actually pharmacology that makes these drugs better for the physiology of a person with a disease of addiction?
Yeah, that's a really hard one, because theoretically there's got to be a reason that oxycodone in some parts of the country, hydromorphone, heroin are preferred. Now, in the case of heroin, the thinking is that it gets into the brain very fast. So it gives that quick onset and offset that people with addiction say they like when they're tested in the laboratory. But in the case of oxycodone, that wasn't the case. So, and there have been experiences like an epidemic of pentazocine abuse years ago, when pentazocine, it wasn't even a pure mu agonist. So why some drugs get popular is really a mystery, and it's probably one of those multi-determinant phenomena that relates to both the pharmacology and the social situation and the availability, the cost. So really no one knows. So we're not reacting to the pharmacology like you see in a book, to a decision about is it safe to put on the street with a patient who might abuse it. We're reacting to information from the street. So we know that these drugs are well liked and high valued, right? At its peak, oxycodone was going for $1 a milligram, right? So an 80 milligram OxyContin tablet was costing $80. And I just prescribed a patient 3,200 of them, a month's supply. Was that right? No, that was probably less. That couldn't have been OxyContin 80. But it was a very large number. It was a very large number. It definitely would be appropriate to give up the whole chairman thing and just sell this stuff, because the income would be so much better and the work would be less difficult. But why that is, you know, it's, and as you know, Terry, when the OxyContin epidemic of drug abuse started, it was actually endemic, right? We didn't have it in New York, right? We never had it here. It destroyed many towns in Appalachia, Pacific Northwest, Maine. And, you know, I went to some meetings and talked to some physicians who were beside themselves because they had 80% rates of abuse in high school. They had multiple kids in small towns having died from recreational use of OxyContin. And, you know, why did that happen? There in Appalachia. Steve Pasek, our colleague, who's now he's now somewhere else, but he was at Sloan Kettering, and prior to going to Sloan Kettering, he was in Virginia, I think Virginia.
I think it was Kentucky.
Kentucky, right? And it was absolutely, OxyContin abuse was absolutely an epidemic in that locale. It was severely out of control. It was a law enforcement problem and a clinical problem, and it took many months to get people to talk to each other. In New York, it was nothing. I mean, New York has drug abuse, and so we know that patients were abusing OxyContin, but they were abusing everything else as well. Why is that? I don't know. Okay, so let's just talk a minute about methadone. Methadone, as you know, has expanding use due to its low cost, and there's certainly an observation that when you switch patients from another drug to methadone, you get potency that's much greater than the equianalgesic dose table suggests, number one. And number two, when you switch patients who are on other drugs to methadone, sometimes you will see something that looks like a much better maximal efficacy. Right? Maximal efficacy means how much analgesia you can get Potency means how much analgesia you get from a specific number of milligrams. So the equianalgesic dose table would suggest that if you give 20 milligrams of methadone orally, you get about the same analgesia as 30 milligrams of morphine. That, of course, is totally wrong. If you switch somebody from a gram of morphine a day, you may have a ratio that is an order of magnitude less than that. So the bottom line is that in certain contexts, methadone has a higher potency than expected and a higher efficacy than expected. So pain specialists have said, great drug. Great drug. We don't really understand why that is, but great drug. So now of course, there's lots of discussion that this is probably related to the racemate in the United States and the rest of the world. Every country in the world sells methadone as a combination of two optical isomers. The L isomer is an opioid, binds to the mu receptor. The D isomer is not an opioid. It's an NMDA receptor antagonist. And we know that blocking the NMDA receptor is both an analgesic mechanism in its own right and also reverses opioid tolerance. So when that was discovered, then it was thought, well, this is obviously the reason that methadone gets more potent, particularly if you give it to people who have already had opioids. You reverse tolerance and you have additive analgesia from the non-opioid mechanism. And in fact, the higher the dose of the prior drug when you switch to methadone, the more potent it is, which fits with the concept that part of what you're doing is reversing tolerance, right? So methadone, that's the explanation. That also drove pain specialists to start to use it more because we felt like we knew what we were dealing with. Germany, by the way, doesn't sell the racemate. If anybody practices in Germany, you're giving 100% L-methadone. So the pharmacology is going to be totally different. And why does Germany have to do something different than everybody else? That's the question the EU is asking right now. Right now. If you didn't want the euro, why did you sign on? Right now. But that's the reality of it. Unfortunately, however, methadone is a very challenging drug to use. And methadone mortality is the highest. Opioid mortality has increased dramatically in the last decade, as I've told you before. The drug that's most problematic in that regard is methadone. And so why is methadone mortality? It probably occurs because of this unexpected high potency. You know, if any of you ever rotated from morphine to methadone and you simply looked at the equianalgesic dose table and then you gave the calculated equianalgesic dose, I can almost guarantee you will kill people. Probably cursing, because after the first one, people are going to stop you from doing it again. But you will almost certainly cause lethality. And then, of course, there also is a variable and a long half-life. How long is methadone's half-life? I can hear you. Yeah, it's actually, the modal is 24 hours, but the range is from 12 hours all the way up to probably 150 hours or even 160 hours. So when you have a drug that you're giving and you're trying to titrate the drug safely, and you're going on the assumption that the half-life is a day, but the half-life may be 4 days or 6 days, you know it's very hard to make a plan in terms of safe titration, right? You try to titrate until a person is at a steady state and watch the patient until they're there, but how long do you watch them for? And then potential for QTC prolongation. Methadone definitely, just look here, methadone prolongs the QTC, and an evidence-based panel will come out with a report soon that says check the baseline ECG if the patient is at risk. So if the patient has heart disease, if the patient's on multiple drugs that can prolong the QTC, if the patient has ever had an ECG with a QTC interval of greater than 450 milliseconds, or if the patient has a history of syncope. So when you're going to start methadone now, there's new obligations on the doctor, right? You have to ask the patient, any problem with fainting? Did you get a cardiogram done? Can you get me a copy? Do you have a history of heart disease? Right? What drugs are you taking? And then you have to go to the little phones you all carry and do something with your fingers that I don't understand. And then you look at it and say, these drugs prolong the QTC. It's extremely impressive that you can do that. But just remember, you do require electricity, and one day we may not have electricity. That's why I keep everything in here, so I don't have to rely on artificial things. In any case, if the patient is at risk, measure the ECG, and remember that 450 or above is a relative, above 450 and less than 500 is a relative contraindication. And it would be good to try to remove other drugs that might be prolonging QTc. And above 500 is a very strong or even absolute contraindication. And the reason is that there is a small but clinically meaningful risk of torsades associated with that prolongation. The reason it's clinically meaningful is because it's a life-threatening arrhythmia. So even though it may occur in less than 5% of patients who get to a QTc above 500 milliseconds, when it happens, the patient has a very bad outcome.
How frequently people suggest with the ECG?
So the guidelines will say that in the person who has gotten a baseline ECG, it would be very important to repeat it at about 2 weeks. And then as the dose goes up, there are no guidelines except for periodically. So if you do significant titration, if you increase the dose by 50 or 100%, you'd probably get another one within 2 weeks of that. For patients who are not at risk, the guideline will say consider getting an ECG after 2 weeks of starting therapy. So again, I think the important thing that is going to be incorporated into these guidelines, which differentiated from the previously published guidelines that got the community, the methadone maintenance community and the pain community quite upset. The previous guidelines basically said everybody needs ECG screening. You know, you need an ECG at least 3 times a day for the rest of your life. That's basically what the previous guidelines said. And the communities said, well, that means we're not using this drug anymore. You know, we can't take methadone maintenance patients who don't have access to health care and get them all of these studies, and pain patients aren't going to pay for them. So, a problem. So a new evidence-based guideline was put together by the American Pain Society and the American Academy of Pain Medicine, and it's incorporating a very important principle of risk stratification, which I like a lot. You know, it just is the way we all think, right? So if a patient has a risk, then look at their ECG and make judgments along the way. Do you need to repeat it? Do you not? It's a low risk, but it's a serious complication when it occurs. Okay. Breakthrough pain is very important, right? Breakthrough pain occurs commonly in both cancer and non-cancer patients. Patients with breakthrough pain have more problematic pain syndromes, more severe pain, reduced responsiveness to therapy, functional impairment, psychological distress, and a higher economic burden. A study shows that patients with breakthrough pain from cancer have more hospitalizations and higher cost of care. So breakthrough pain is a big problem. And the characteristics of the breakthrough pain are highly variable, which means you have to assess breakthrough pain separately from background pain. You have to ask the patient how often they get it, how long it lasts, is it very rapid in onset, and is it predictable? So you need to ask these questions because they influence how you treat breakthrough pain. In the patient with serious medical illness like cancer, the co-administration of a short-acting drug along with a long-acting drug is a standard of care in the U.S. In patients with non-cancer pain, the co-administration of a short-acting drug is not a standard of care. And that suggests something for your documentation as well. If you decide in a patient with low back pain that you want to give the patient a long-acting drug and then a short-acting drug for breakthrough pain, it'd be very helpful, particularly now and particularly at your points in your careers, to document why you're giving the patient a short-acting drug, that you made this decision separately, because it's not a standard of care. In contrast, if you don't prescribe a drug for breakthrough pain in the patient with advanced cancer, you're violating a standard of care, unless the patient has no breakthrough pain, and most of them do. So how do you treat breakthrough pain? You assess, treat the underlying etiology, make sure that the long-acting drug is optimally titrated, and then use a specific treatment for breakthrough pain. The treatment for breakthrough pain is called a rescue dose, as you know. Standard of care for patients with serious illness, not a standard of care for for non-serious, for patients without serious illness. The conventional approach has been in the past, for the past 30 years, same drug and route as the baseline pain, with the starting dose 5 to 15% of the baseline daily dose. That's been the standard of care. But of course now in the past 10 years, there's rapid onset fentanyl formulations have been commercialized. And the issue with these drugs is that they definitely have a faster onset of effect. Not instantaneous, right? Like Actic, for example, has an onset of effect at 15 minutes only for about 10-15% of patients. Most patients are waiting 30 to 45 minutes for an effect. But Fentora is faster than Actic. And Lazenda, the new nasal spray, faster than Fentora. So the pharmaceutical industry has been working to try to get drugs with faster onset of effect, because most pains occur quicker than an oral drug would be optimal to treat them. Right? So recognizing that and recognizing breakthrough pain as an unmet clinical need that could potentially generate a lot of profit, the pharmaceutical industry jumped into this, beginning with the development of oral transmucosal fentanyl citrate, Actic. And when Actic turned out to be a commercial success, many companies jumped in. And these are the drugs that are now available in US and Europe. OTFC is available here and in Europe. Fentora, or the buccal tablet, available here and in Europe. The BIMA patch, the bioerodible mucosal adhesive patch, is available here. That's on Solace. The sublingual fentanyl tablet, Abstral, available here and in Europe. The fentanyl solution nasal spray, fentanyl and saline, is available in Europe, not here yet. And the fentanyl pectin nasal spray, where fentanyl is mixed with pectin so it adheres to the nasal mucosa and you get more of a controlled release into the nasal mucosa, that just got approved. That's called Lazenda. That will be in the pharmacies within a couple months from now. We did a lot of studies of that here. Definitely works. It works fast. It's obviously a lot more expensive than oral morphine or oxycodone. So, by the way, just to show you, companies are now working on these. 3 companies have been doing studies of inhaled fentanyl. Talk about a fast onset of effect. Those of you who do anesthesia for a living, that concentration time curve looks just like an IV bolus.
Is there any data suggest that there's more abuse potential with these rapid onset? Because I mean, you'll see patients that come in, be on the same drug class, and they say, "Oh, it doesn't work. My pain's not controlled with long-acting fentanyl patches," and then they'll be like, "But I need Fentora," and then you're like, "Well, how much are you using?" And they use every single rescue dose for the entire month.
Right.
Well,
So these are really 2 separate observations. The patient that uses every rescue dose is not just a rapid onset fentanyl phenomenon. That's a phenomenon during long-term opioid therapy. Some of those patients are undoubtedly problematic and are taking the short-acting drug because they crave. They have a craving phenomenon, or because they have interdose withdrawal, and they're trying to prevent interdose withdrawal. But some of those patients presumably are benefiting from a combination of 2 pure mu agonists. So for example, I have now a stable of patients that I've been treating. I thought it was 15 years. I actually checked. I've been treating the patient I saw yesterday for 21 years. And I have a stable of patients doing that for decades, taking 2 drugs, 1 long-acting, 1 short-acting, and they basically come in every month, and I refill their short-acting in the same amount every month. So they're taking 2 drugs every month. And there's no evidence of aberrant drug-related behavior, no evidence of functional decline related to the drug. So what am I looking at? Am I looking at a problematic pattern of use, or am I looking at a patient who's choosing to use 2 opioids? Now that's different than the other question, which is some patients say the short-acting drug works better, and I take the short-acting drug when my pain flares, and the rapid onset works better. That's another potential reason that someone could say the short-acting works better. But there's also no question that there are concerns related to the rapid onset drugs, and one of the concerns is attractiveness to those with addiction, right? Now that's been a theoretical concern ever since OTFC came out, which I think now is 12 or 13 years ago, because as I mentioned before, if you take people with the disease of addiction and you test them in the laboratory, onset and offset are two characteristics that drive their liking of a drug in any class, any abusable class. Onset and offset. And lipophilic drugs are preferred over hydrophilic drugs, presumably because they cross the blood-brain barrier faster. IV bolus is preferred over subcutaneous injection because you get a faster entry into the brain. So drugs that are lipophilic that you stick against your mucosa or you squirt up your nose or you inhale presumably have a high risk of abuse. So far, there hasn't been much abuse. It's basically been on the blogs or the drug abuse websites. I'm sure all of you are visiting these websites and contributing frequently. But there are drug abuse websites that you can go to and learn how to abuse any drug in America or internationally. So there is some abuse going on, but it hasn't been large yet, presumably in part because there hasn't been that much access. So the issue is the cost-benefit issue. That's the biggest one, right? It's certainly a lot more expensive. And the conclusion I think the conclusion is if the patient's payer or the patient's self-pay would allow the patient to try a rapid onset, and they have a very rapid onset of pain, or they don't do all that well with an oral, try the rapid onset. So if you give them oral morphine and you give them oxycodone, they don't do that well for their breakthrough pain, consider switching to a rapid onset. If they have a breakthrough pain, for example, the patient with metastatic prostate cancer who is doing pretty well, but when he stands up and walks, every so often, 5-6 times a day, he gets a flare of mid-thoracic and lumbar pain, which lasts 15 minutes. Makes him go to bed and lie down before he can walk again. So how are you going to manage that? So you probably say, well, try to take your oxycodone when that happens. And he says, I take it, but by the time it works, the pain's gone. So you can fool around with a dozen different oral drugs. It's not a high-yield proposition that you're going to treat that pain. You can't prevent that pain because what are you going to tell them to do? Sit in the chair and don't plan on getting up from the chair for another 45 minutes until your pain comes on, and it only comes on a few times a day, so you got a problem. It's that kind of patient who can theoretically have a dramatic benefit. And if you've ever gone to a drug company-sponsored meeting, symposium on this, they all have their films, their little videos of patients whose lives were changed by having access to a rapid onset fentanyl drug. And the thing to remember is that they're real people, their lives were changed. It's not the same as a comparative effectiveness study, right? But it's an anecdote. And that's how we mostly practice medicine, from the accretion of anecdotes. So that's the bottom line. You should. My feeling is this is a good year to at least try to learn how to use the rapid onset formulations. One thing to remember about this, always start the rapid onset formulations at their lowest doses. So in contrast, if you give somebody a gram of morphine switched from oxycodone, you probably want to give that patient a rescue dose that might be 90 milligrams of morphine. Might be somewhere between 5 and 15%. And not a lot of data that's necessary, but there's a tremendous amount of observational experience. On the other hand, all of the studies of the rapid onset fentanyl formulations have demonstrated that there's no relationship between efficacy and the baseline, the background dose. No relationship. Now, why that is, no one knows. Maybe it has to do with how fast it gets in. But the bottom line is, if you're going to give Actique or Fentora, if you're going to give Actique, you start with 200 mics a dose. If you're going to give Fentora or Ansalus or Abstral, you start with the 100 or the 200 mic dose. Lazenda, you start with the 100 or 200 mic dose. Even though they weren't forced to do this by the FDA, all of the drug companies have selected their dose range similarly. They all start at 100 with the exception of Actique, which starts at 200. Right? So I just would always say start with 100. Now, not everybody agrees with me, but they're definitely wrong. All of the data. I mean, if you just look at the data, if you believe in data at all, and I don't believe in it all that much, but if you believe in any data, multiple studies have shown the same thing. The likelihood that a dose of these rapid onset fentanyl formulations will work has nothing to do with how much of the other drug they're taking. Period. So, and clearly, if a patient could respond to 100 and you choose to give that patient 600, you're taking more risk, right? Because risk is dose dependent. Okay. So let's talk a little bit about some guidelines. You all know that where the rubber meets the road is individualization of the dose, right? All opioids work. People vary in how they respond from one to another. The only way you're going to know if a drug works is to titrate the dose. That's the key thing. Now, please, I'm not going to talk about it today, but I really appreciate the opportunity during the course of the year to spend a little time with the pain docs and the palliative care docs talking about rapid titration strategies. Because in my experience, even physicians who are comfortable with opioids will often force patients with very severe pain to wait a good long time because they don't feel comfortable with rapid titration. So the bottom line is that titration always needs to be considered in a standard ambulatory context. A titration can occur from steady state to steady state. With morphine, oxycodone, you're talking about changing the dose every few days. With methadone, you might be talking about changing the dose once a week. You typically can increase the dose by 30 to 50%, sometimes a little more. It's very standard, it's simple. It's like other drugs, not a problem. It's when patients are in the hospital or in the nursing home or coming into the office and they have very severe pain. And if you think about taking a patient with very severe pain and saying, you know, take this drug and call me in 4 days, it's really cruel. And in the hospital, PCA has definitely lifted your burden to some extent, but I'm not really happy with that either. Because unless you sit down and you actually calculate how much drug a patient can get via the PCA and you feel comfortable that the patient is physically able to dose themselves the way you think you might want to dose them if they had severe pain, you're not doing them any favor. It's just an excuse. Remember, most people don't push the PCA button when they're asleep. So if you have a patient with very severe pain and you say, just load yourself up, boom, 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 don't worry, take a nap, and then they wake up and they're screaming, it really reflects terribly on me. So we won't talk about that, but I just want to make you aware, titration is the rule. Individualization of the dose is what distinguishes the ability to have positive outcomes from not positive outcomes. You have to know how to do that. And then if you individualize the dose, the standard simple approach is not hard. All of you already do it. It's the patients who are more problematic, the ones who are at high risk of opioid toxicity. Right? We encountered 2 patients last month presented at M&M who had near respiratory arrests in the acute pain setting. We're going to have an RCA on that in the department. We're going to figure out if our standard titration strategy needs to be adjusted for patients at risk. So patients at risk and patients with severe pain require specialist input. And since all of you are specialists, I want you to know how to do that. But we're not going to talk about that today. I just want to talk to you about this quickly. You will encounter, and you probably have already encountered, patients who come in and you say to the patient, I'd like to give you a trial of the patch. And the patient says, tried it, it doesn't work. Or you say, I'd like to give you some OxyContin, and the patient says, tried that, doesn't work. What's the next thing that you should say? Say again?
What do you do when you say it doesn't work?
Yeah. Right. And the goal of that assessment is you're trying to find out if they developed treatment-limiting toxicity. Because in the absence of treatment-limiting toxicity, you have not determined the responsiveness of the patient. This is a very important concept. I love this concept because I invented it. It's true. I did. But I invented it for a very good reason. Because doctors needed a hook, something to understand when they should think about next steps. Because what happens in the real world, you probably know this already, is patients are kept on inadequate therapy for a long, long time. Or the doctor assumes that a therapy is going to be inadequate because a patient makes a comment about a prior therapy without understanding whether or not their prior experience relates to their ability to respond to that drug. So I invented a construct called responsiveness, opioid responsiveness. And I said, you know, opioid responsiveness is patient-specific, drug-specific, and route-specific. So if I'm giving a drug to a patient, it is only in that individual patient with that drug, with that route, can I say this patient is a non-responder or a poor responder to that drug. So when a patient comes in and says, OxyContin tried, it didn't work, I said, well, did you get side effects from it? And then, in my experience, sometimes yes, sometimes no. They may say, no, you know, the doctor told me to take 2 tablets and it didn't work, so we switched. Okay, did that patient have a trial of OxyContin? No. Patient didn't have a trial. It wasn't that it didn't work. There was no trial. It was as if the patient was just given placebo. Right? Never had a trial of the drug. Because unless you titrate to treatment-limiting toxicity, you can't ascertain if the patient has a potential to respond. Okay? Now, the other reason that I really like this concept is because it's a driver for clinical change. See, doctors, I think, get into this pattern of sort of not critically evaluating the outcomes in terms of the ideal. You know, patient comes in, the worst scenario, obviously, is someone comes in with non-cancer pain who says the opioids take the edge off. And meanwhile, they're functioning poorly. You know, they're sleeping poorly, they're fatigued, they can't work, they're functioning poorly in the family. The drug only takes the edge off. They still have 8 out of 10 pain, and the therapy is continued indefinitely. So the whole pain management community is worried about that scenario. We tend to blame primary care, but it's actually our problem too. The regulators are blaming everybody because some of those patients go on to abuse the drug. So we have a big problem in not recognizing that scenario as an inadequate outcome. In a similar way, somebody with advanced illness will say, I'm better, I'm better. And when you start asking more detailed questions, you find out, well, they're better, but they can't function, they're still not sleeping, they're irritable. So the bottom line is, if doctors can be taught that outcomes can be dichotomized, you know, it's not easy because everything's on the bell-shaped curve, of course, but the bottom line is you're either going to prescribe or not. So the clinical decision is dichotomous. You're either going to continue the therapy or you're not. On what basis do you continue or you're not? If you're not going to continue, you want to rationalize that by saying the patient's poorly responsive. And so one of the reasons that I invented this construct is because I want people to say, I have to change the therapy. I have to do something different now. I have to give the patient an opportunity to try neuraxial analgesia. I have to give the patient an adjuvant because they are not responsive. Okay, I'm going to end with this. And as usual, I didn't get to talk about side effects, which is great because side effects are really worth an hour. So we'll have another session on side effects. But this is when the term poorly responsive pain was created, it led to another construct, which is what do doctors do if they encounter poor opioid responsiveness? What do you do? And one of the things that makes me quite distressed is when specialists only seem to have one answer, because that's not why you became a specialist. You know, you became a specialist so that if you encounter a challenging clinical scenario, you have more than one answer. Or you know what you don't know and you know who to ask. It bothers me when people say, oh, you know, we'll put a catheter in. Okay, what else did you think about? Well, we put a catheter in. Well, in palliative care, it's opioid rotation. You know, our colleagues have got that, but they don't know about putting catheters in. So that's the answer. So I don't like that. I'd much rather have you take a step back, say this patient's poorly responsive to morphine. What strategies are available to me? And I would ask you to think about the strategies in 4 buckets. The first bucket is to do something to better manage the side effects. So if they have if their therapeutic window is shutting, you might be able to open their therapeutic window by treating the side effect. So a sleepy patient rendered alert by giving them a psychostimulant opens the therapeutic window, and a poorly responsive therapy becomes a responsive therapy, right? Opioid rotation, which we'll talk about at another time. A systemic drug strategy to lower the opioid requirement. This is where you might want to add the NSAID. I just had a wonderful outcome of a patient who had persistent pain after a knee replacement and was developing a chronic impairment in her functioning, despite opioid therapy, aggressive PT. And I just forced her to take anti-inflammatory doses of an NSAID. She was very reluctant. And swelling is now just about gone. She has full extension, another 5 degrees to go. She's doing dramatically better. So that was a case of someone who had pushed the dose of the opioid up to where she was a little bit loopy, and she was doing the best she could. And she said, I'm doing the best I can. And I said, you're poorly responsive to that opioid. Now, we could rotate to a different opioid, but you know what? There's a lot of inflammation there. Let's do a systemic drug trial of a different type to see whether or not we reduce your opioid requirement by giving you an anti-inflammatory drug. And then the last one are other strategies, which include interventional pain management, psychological strategies, CAM strategies, physiatric strategies, neurostimulatory strategies. Right, so there's 1,000 strategies in those 4 buckets. So you have to stop, think, which strategy makes sense in this person. There are no comparative data, so it's pure clinical judgment. My patient with the knee replacement, I could have put an epidural catheter in. I could have given her opioid rotation. I could have given her a psychostimulant and pushed the opioid. I could have given her an NSAID, or I could have given her an adjuvant analgesic. I chose an NSAID because of the way her knee looked. And I talked to her about the epidural, which was next. Okay, so titrate, select the drug, select the route, push the dose appropriately, and then determine whether or not the patient responds. And if they don't respond, label that patient as poorly responsive to that drug and that route, and then consider the strategies. And next time I see you all, we'll talk about side effect management, because that's an important strategy that's been evolving a lot with new therapies. Any questions?